Hi, welcome all to this episode of Conceptual Anesthesia. Today we will be taking a slightly different topic than regular ICU things like sepsis and ABG. Again, this is kind of a syndrome and which is being talked more and more nowadays. It is commonly called as HLH. It is Hemophagocytic Lymphohistiocytosis. So that is the full form of HLH. Okay, and more you work in the ICU over the next few years, I feel this will be talked. So it is better to have a basic for this and then we can start. This can come in few MCQs. This can come as a short note in critical care sections. So even for the exam point of view, you should have a fair idea about it. At least what to write if there is a short note. The topics that we'll be covering are the introduction, pathogenesis, classification, primary and secondary, and latest guidelines. So as introduction, HLH, as we commonly call it, is a potentially life-threatening syndrome characterized by dysregulation of immune cells, excessive production of cytokines, extreme inflammation and tissue damage. So it has got something to do with the immune system. And there is dysregulation of immune system. There is excessive production of cytokines leading to inflammation and tissue damage. It can be an indolent or a self-perpetuating hyperinflammatory cytokine storm. So like sepsis can lead to cytokine storm, HLH can also lead to a cytokine storm. And the issue is that it can be triggered by many things. It can be triggered by infection, malignancy, rheumatological disease, and has got a very high acute mortality rate of 40%. So that is why we all need to be aware about this. As with all things, early recognition and treatment potentially improves outcomes. And there is a huge overlap in sepsis in both clinical features, pathophysiology, and crucially, sepsis can act as a HLH trigger, whereas HLH patients are also susceptible to sepsis. So they can go hand in hand. So there is a growing recognition for the complex interplay between inherited, acquired, and environmental form of LHH. HLH initially was called by different names. We must have heard previously about macrophage activation syndrome, hyperferritinemic syndrome, and sepsis HLH overlap syndrome. And HLH can occur at any age. So this is the whole gamut that HLH can occur from pediatric HLH to a macrophage activation syndrome or a malignancy associated hemophagocytic syndrome. So infection and malignancy are the two very common things that can precipitate HLH along with the rheumatological disease. So it is caused by a failure of the negative feedback loops that normally control inflammation. And the result of this is regulation is persistent immune activation and self-perpetuating. That means the self-perpetuating means that it can go on by itself in a circular fashion. Hyperinflammatory state, which can lead eventually to a cytokine storm. And the clinical sequelae that you can see is fever. Cytopenias, usually the patients have bicytopenia at least. End organ damage, so various organs like the liver and the kidney can get damaged. And in some cases, hemophagocytosis is evident on the biopsy of bone marrow or other tissues. Remember, despite this syndromic name of HLH, hemophagocytosis need not be present and is not essentially required for the diagnosis. Again, this can come as a MCQ. So there nowadays we are all evaluating, we tend to have a genetic basis for both primary and secondary forms. It can be a familial HLH, which is a genetic disorder, or a secondary or a acquired HLH. And again, as I told you, it can be triggered by many things: infection, hematologic or other malignancies, rheumatologic or autoimmune disease, chemotherapy, stem cell transplant. So practically most of the serious things that we encounter can trigger HLH. The primary or familiar is usually in infants and children, and the secondary or acquired or reactive is usually in adults. And there is absence of no tends to occur at a later age. So this is the whole idea how the whole pathway for HLH can happen. So individuals are usually susceptible because of either the genetic thing which happens usually in the infancy or childhood, or there is a background inflammation because sepsis or autoimmune things or malignancies can trigger. So when they trigger, there is an uncontrolled immune activation. So usually the immune activation is controlled, but here what happens? There is uncontrolled immune activation, And there's a self-perpetuating cycle. As you can see, there's a circular motion in the red box. So there's a self-perpetuating cycle, and this leads to hyperinflammation and organ damage. So there's an underlying defect in the natural killer cells, and CTLs on the background of pre-existing susceptibility leads to failure of, so they don't can't clear antigen from infected tumor, autoimmune, or antigen presenting dendritic cells. And again, as I told you, there's a cytokine storm. So we'll be going through all the triggers that can lead to HLH. One of the major triggers is infection, and here the first or most common is the viral infections, and predominantly the Epstein-Barr virus. So remember, this can again come as a MCQ, Epstein-Barr virus. Other herpes virus, CMV, adenovirus, hepatitis virus. So all kind of things can lead to. So dengue can lead to HLH. So we can see that in the critical care settings. Bacterial infections can be reported to lead to HLH, which is around 9%. Even the parasitic leishmaniasis can lead, fungal infections can lead. But here the viral one is the most common infective trigger, and which is the most common virus, Epstein-Barr virus. So secondary HLH, as SHLH is called, can be a direct consequence of malignancy or result of cancer treatment. So even the malignancy can trigger that, or cancer treatment like hematopoietic stem cell transplantation, chemotherapy, immunotherapy. So all of these are getting more common nowadays. As you can see, oncologic part of the critical care settings are getting more and more common. So we are encountering HLH much more than before. And most commonly it is associated with hematological malignancy, in particular lymphomas. So again, which malignancy? Hematological lymphomas. Potentially, HLH being used nowadays is CAR T cell therapy, which is chimeric antigen receptor T cell therapy, and dendritic vaccines. CAR T cell therapy is strongly associated with overproduction of cytokines, and again, this leads to systemic inflammation and organ dysfunction. Then, as I told you previously, it was called macrophage activation, and this was more common related to the autoimmune or rheumatological diseases. There's a strong connection with systemic juvenile idiopathic arthritis and adult onset Still disease and SLE. So these are the three common things which can come in the autoimmune or rheumatological things which can lead to this macrophage activation syndrome, and nowadays it's called HLH. Now sepsis, as I told you, there are both similarities. Sepsis can lead to HLH. HLH patient, when you treat them, they can immunity can go down, they can lead to sepsis. So the both conditions share similarity in their pathophysiology, cytokine profile, and clinical features. SLH may be present in the absence of infection, but again, it can cause identical things like septic shock. So it can be a sepsis mimic. So secondary HLH can be triggered by infection or predisposed to sepsis, as I told you. And both conditions coexist in the context of an underlying disease. Suppose the patient has a malignancy or autoimmune disease. This can trigger both the things, secondary HLH and sepsis. So from a practical perspective, secondary HLH could and probably should be suspected in all critical ill patients. So what are the common presentations? Unexplained fever, usually bicytopenias, and organ dysfunction. And I'll tell you how we evaluate these patients, and especially the patients who are not responding to aggressive systemic sepsis treatment. Just to show you what all things can lead to HLH. So we've covered till now. So the patient presents with fever, organ dysfunction, and lymphadenopathy. Lymphadenopathy may or may not be there, and the patient usually has hepato or splenomegaly. A combination of cytopenia and transaminitis is usually there. So when you suspect a patient is not getting better. He presents to you with some fever. You suspect some kind of viral infection. There is hepato or splenomegaly. So when you try to evaluate these patients has raised ferritin, elevated triglycerides, and low fibrinogen. So when such kind of setting is there, you can think about HLH. You obviously have many other diagnoses in mind, but HLH also should be thought about.